All right, let's jump right into this rapid review of some super high-yield clinical cases. No fluff, just the core info you need to know.
First up, we're going to tackle pathologies of the head and neck. These are great because the localized signs and symptoms often point you directly to the right answer.
So, picture this. You've got a patient with a long history of ear infections. Nothing new there. But now, they're coming in with vertigo and facial weakness. Your brain should immediately be screaming complications.
And here's why. You can practically trace the path of that infection. It can crawl right into the neighboring mastoid bone, causing mastoiditis. If it goes deeper into the inner ear, boom, you get labyrinthitis, which explains the vertigo. And since the facial nerve runs right through there, it can get inflamed too, leading to facial palsy. So the diagnosis is pretty clear. It's all from the direct spread of that chronic ear infection.
Okay, here's the stuff you absolutely need to remember. First, the clinical pearl. Don't get this mixed up with otosclerosis. That's a bony disorder, totally non-infective. And for your exam, the critical point is the mechanism. It's all about the direct extension of the infection. And remember, this can spread all the way into the brain and form a life-threatening abscess.
Let's switch gears to the next case. A 45-year-old walks in with a single lump they can feel in their neck. The classic solitary thyroid nodule. But here's the million-dollar question. Is it truly solitary?
See, the problem is, what you're feeling might just be the tip of the iceberg. The biggest, most dominant nodule in a gland that's actually full of them. Your fingers alone just aren't reliable enough. So our working diagnosis isn't solitary nodule, it's apparent solitary nodule. And that's our cue that a full workup is needed to figure out if we're dealing with something benign or, potentially, malignant.
So what's the bottom line here? First, the next step is always going to be imaging. You have to see the whole gland to know what you're dealing with. And second, for exams, the core concept is to be suspicious. Never, ever assume a lump you can feel is just a single harmless lesion. You have to prove it's not something more serious.
All right, on to our second big theme, spinal cord compressions. And let me tell you, these are true neurological emergencies. Every single minute counts.
Okay, check out this clinical picture. Someone says their hands feel clumsy. You notice their biceps are wasted away, but then you check their legs and they're stiff and spastic. This weird mix of symptoms is a huge clue that points to a very specific spot.
And this is just a beautiful illustration of the pathology. Right at the level of the problem, let's say C5-6, the nerve root itself is getting squished. That gives you lower motor neuron signs, like the wasted biceps. But everything below that level, the whole spinal cord, is being compressed. That's what causes the upper motor neuron signs in the legs, like the spasticity. It's a perfect match for cervical spondylosis with myelopathy.
So what's actually going on? It's just wear and tear degenerative changes, things like disc protrusions and bone spurs, that are squeezing both the nerve root and the spinal cord at the same time. The absolute high-yield point for any exam is this. When you see lower motor neuron signs in the arms and upper motor neuron signs in the legs, you need to think cervical myelopathy. It's the classic pattern.
Okay, next case. And the stakes just got even higher. Severe back pain, weakness in both legs, and, this is the big one, new-onset urinary incontinence. When you hear these symptoms together, alarm bells should be ringing loud and clear. The fact that the symptoms are bilateral tells you this is a central problem, something big compressing the middle of the spinal canal. But the absolute most critical red flag is any kind of bladder or bowel disturbance. That loss of control is the hallmark sign that elevates this from a back problem to a neurologic emergency, Cauda Equina syndrome. So what do? The answer is non-negotiable. You get an urgent MRI right now. You have to see what's causing the compression so you can decompress it. And the exam point here is a safety one. Once those sphincter symptoms start, conservative treatment is not just wrong, it's dangerous. You have to image immediately or risk permanent damage. All right, for our final section, we're zooming out a bit to look at conditions that affect the nervous system more broadly, giving you these really widespread patterns.
Now check out this interesting cluster of signs. A 40-year-old guy says he has trouble letting go after a handshake. You notice he has kind of an expressionless face, and he mentions he's had cataracts. This unique combination points to a very specific multisystem disorder.
Let's break this down. The weakness pattern is key. It's distal, in the hands, and involves the face. That trouble letting go of his grip? That's not just weakness, that's myotonia, a delayed relaxation of the muscle.
But the real clincher is the systemic stuff, the cataracts, a receding hairline, even testicular atrophy or heart problems. Put it all together and you've got dystrophia myotonica.
So the big clinical pearl here is to think beyond the muscles. This is a multisystem disease. For exam purposes, the key takeaway is that classic triad: distal weakness, grip myotonia, and systemic features. That's what will help you confidently separate this from other neuromuscular conditions.
Now for a super common scenario. A patient with long-standing diabetes comes in complaining of burning feet and numbness. But here's a really important detail. They say it's been pretty much the same for the last 2 years.
That chronic symmetrical story immediately makes you think of something metabolic, like diabetes, rather than an acute inflammation. And what's really interesting is that diabetes attacks both large and small nerve fibers. This means you get signs of large fiber damage, like losing your vibration sense, and signs of small fiber damage, like that burning pain. It's this mixed picture that is classic for diabetic sensory motor neuropathy.
So for your exams, you have to recognize this combination of both large and small fiber signs in that classic stocking glove pattern. And it's crucial to be able to tell it apart from something that comes on fast and furious and is mostly motor-related, like Guillain-Barré syndrome, which, hey, is our very next case.
And what a perfect transition. Here we have a patient who just got over a stomach bug. And now, over just 3 days, they've developed weakness that's moving up their legs so fast they can barely walk. The key word here is rapid.
Now, this comparison to MS is absolutely critical. Look at how different they are. GBS is acute. It happens over days. It's symmetrical. And here's the money shot: areflexia, meaning the reflexes are gone. MS, on the other hand, is chronic and relapsing, often asymmetrical, and causes hyperreflexia, brisk reflexes. The reflex exam is everything here.
So, to wrap this all up, remember that GBS is an acute inflammatory attack on the nerves, but the diagnostic triad you need burned into your memory is acute, symmetrical, flaccid weakness with areflexia. You see that pattern, especially after an infection, you have to think GBS until proven otherwise. And that's our final high-yield point.